Welcome to the American Rhinological Society 9th Annual Summer Sinus Symposium virtual meeting. I'm Dr. Pablo Stolovitzky, President of ENT of Georgia North, a 20 otolaryngology group practice in Atlanta, and adjunct assistant professor at Emory University. We have a distinguished panel of experts that will discuss sinus and Eustachian tube balloons, which, how, and when. Our first speaker is Dr. Rohin Rathatha, rhinologist at ENT and Allergy Associates in New York City and faculty at the Icahn School of Medicine at Mount Sinai. Dr. Rathatha will discuss pearls, pitfalls, and indications of balloon sinuplasty. Rohin?
All right, well, thank you so much for having me on this panel. And as you mentioned, Dr. Stolovitzky, I'm going to be talking about balloon sinus dilation. So the first thing that I wanted to go over was our Academy's position statement on balloon sinus dilation. And I'm just going to read through it, and this is published as you can see below. So sinus ostial dilation, for example, balloon ostial dilation, is a therapeutic option for selected patients with CRS and recurrent acute rhinosinusitis who have failed appropriate medical therapy. The clinical diagnosis of CRS and RARS should be based on symptoms of sinusitis and supported by nasal endoscopy documenting sinonasal abnormality or mucosal thickening on CT of the paranasal sinuses. This approach may be used alone to dilate an obstructed sinus ostium, the frontal maxillary or sphenoid, or in conjunction with other instruments, for example, the microdebrider or forceps. The final decision regarding the use of techniques or instrumentation for sinus surgery is the responsibility of the attending surgeon. So that's from our Academy. Next slide, please. Our Academy also put out in 2018 a clinical consensus statement on balloon dilation of the sinuses. Next slide, please. So there are a few statements here that reach consensus, and these were on patient criteria. So I'm going to read through these because I think these are all important. So balloon dilation is not appropriate for patients who are without both sinonasal symptoms and positive findings on CT. Balloon dilation is not appropriate for the management of headaches in patients who do not otherwise meet the criteria for CRS or recurrent acute sinusitis. Balloon dilation is not appropriate for the management of sleep apnea in patients that don't meet criteria for CRS or recurrent acute sinusitis. And CT scanning of the sinuses is a requirement before balloon dilation can be performed. Balloon dilation is not appropriate for patients with sinonasal symptoms and a CT that does not show evidence of sinonasal disease. And it's not appropriate as an adjunct procedure for FES in patients who have nasal polyps. Balloon dilation can be used in persistent sinus disease in patients that have had previous sinus surgery. And there is a role for balloon sinus dilation in managing our patients with recurrent acute sinusitis based on symptoms and CT evidence of ostial occlusion and mucosal thickening. Next slide, please. So just a quick sort of summary of that, going through indications for sinus balloon dilation. So it's CRS without nasal polyposis. Typically, it's limited disease affecting the maxillary, frontal, and sphenoid sinuses. Recurrent acute rhinosinusitis, which as we know is defined as greater than or equal to 4 bacterial sinusitis episodes in a year. Now, patients must have failed maximal medical therapy. They must have a CT scan that shows mucosal inflammation and or ostial occlusion. And they should overall be candidates for endoscopic sinus surgery. It's just at the site of service, we might want to do this in the office with a balloon as opposed to in the operating room. And certainly in patients that have contraindications for general anesthesia, doing a balloon dilation in an office-based setting is certainly a great option for them. Next slide, please. This is my particular office setup. As you can see here, I have a Medtronic system, which I'll talk about in a little bit, and that's the Medtronic Compact Fusion system you can see in the background. And I have a couple of Mayo stands set up with instruments and have a video tower as well. Next slide, please. So a few pearls. One is, one of the biggest complaints that I feel like patients have is not the actual, sinus dilation procedure itself, but it is about the taste of the anesthetic and the numbness and throat sensation as the anesthetic drips down. So I definitely want to inform patients about that ahead of time and let them know that they shouldn't eat or drink anything until that sensation passes because of the globus sensation that they can have. Also, if you are going to do any injection with a local anesthetic with epinephrine, it's definitely important to advise patients of the temporary tachycardia effect that they can have. I don't routinely do any injections for my balloons because I can do them under topical anesthesia quite well. But if I do need to inject, I do use a topical anesthetic with 1 to 200,000 epinephrine. And certainly before you dilate a particular sinus, it's important to let the patients know that they will hear a crackling of bone sound and feel some pressure in the afflicted sinus. Next slide, please. So I use the Medtronic Nuvent balloon system. It is the first sinus dilation system that is tracked by Medtronic's Fusion ENT navigation system. And there's a separate maxillary, sphenoid, and frontal balloon. Next slide, please. So there's a few reasons why I use the Medtronic system. First and foremost, I have comfort with the Medtronic navigation system. So I've used the Fusion system on the OR for many, many years, and now I use the Stealth system. And in the office, I've had Fusion and now the Compact Fusion system. So I'm very familiar with their navigation system, and I love the accuracy. And I love that you can navigate not only to balloons, but also other instruments like debriders if you're doing a hybrid procedure in the office too. The rigid balloon that Medtronic does offer can also be used as a dissecting tool. It can help keep your turbinates out of the way. And the fact that there are separate balloons does allow for cost savings because you can open up, one or two balloons instead of having to have a pack that has all balloons included in one. Next slide, please. There are other companies that have great balloons out there as well. Acclarent and Stryker, formerly Intellis, both had balloons that have historically been used with light illumination, but they have also partnered with navigation systems, Acclarent with the Trudy system and Stryker with the Scopus navigation system. So physicians do have the option of using navigation with their balloons now as well. Next slide, please. I'm going to go through one case here, which is a 51-year-old female with persistent right-sided headaches, and she presented to an ER where a CT of her head showed an isolated right sphenoid mucocele. She was treated with oral antibiotics, oral steroids, nasal steroids, saline rinse without improvement, and then a second round of antibiotics, and still wasn't getting any better. And she had a nasal endoscopy that showed no purulent discharge from the right sphenoidal recess. Next slide, please. You can actually advance a couple of slides, just because all the images will pick up. There's 3 in total. Thank you. So actually back 1 slide, please. So this is a coronal non-contrast CT of the sinuses, where you can see this isolated right sphenoid opacification with some hyperostotic changes around the sphenoid sinus. What doesn't really pick up is there was some hyperdensity within the sphenoid sinus, which looked like a fungal lith, but the bony walls are completely intact. Next slide, please. There are 2 axial images and 1 sagittal image. Thank you. So here you can see on the axial images, it's isolated to the right sphenoid sinus. The ethmoids are clear, and on the sagittal image, the skull base is completely intact around. Next slide, please. So this is the patient's pre-procedure nasal endoscopy. I'm on the right side. I'm going in between the middle turbinate and the septum, and now we're seeing the superior turbinate, and I'm seeing the sphenoidal recess here. And next video, please. So here I am using the sphenoid balloon from Medtronic, and I'm going in that sphenoidal recess and using navigation as I'm tracking, and I'm going right to the sphenoidal recess to the natural ostomy of the sphenoid sinus. And once I know that I'm in incorrect position, I will enter into the right sphenoid sinus, and then I will do a few dilations. And you'll see that there is some mucopurulent discharge that's coming out after doing the balloon dilation itself. Next slide, please. So here I'm just tracking with the balloon itself. As you can see, the balloon is posterior. I did not do my dilation there. I dilate at the natural ostomy itself. But here I was just doing teaching, showing the posterior wall of the sphenoid sinus. Next slide, please. And here I am now using a navigated suction to go into the sphenoid sinus that I have now previously dilated to evacuate the contents. And as we sort of saw from the initial CT, there was evidence of a fungal lith. And here I am able to suck. And I can suction out some of the mucopurulent discharge. And I did do a culture as well. Next slide, please. And here's a navigated view with the Medtronic system showing the suction within the sphenoid sinus. And I'm in a very safe place. Next slide, please. And here is the post-procedure endoscopy. And you can see that the balloon has done a very nice job of dilating that sphenoid sinus, and I'm able to get a nice visualization into that sphenoid sinus. And next slide, please. So her headaches improved almost immediately. Her cultures came back as Klebsiella. We treated her with culture-directed antibiotics, and she overall did great. And about 3 months later, she actually presented back to her original ENT with contralateral headaches and was sent for another CT of her sinuses that I'll show you guys. Next slide, please. And what I want to show you here, you can pull up the next, there's one more image. You can see that on the axial images, the sphenoidal recess has been dilated now, and there's just a little bit of posterior inflammation seen in the sphenoid sinus. And overall, that sinus looks great, and the contralateral side looks normal. So the patient actually had to go see a neurologist for headaches. Next slide, please. So thank you guys very much.
Thank you, Dr. Athatha. Our next speaker is Dr. Jane Lee Stoken, Assistant Professor and Program Director at the Mayo Clinic in Rochester, Minnesota. She completed her residency and fellowship training in rhinology and skull-base surgery at the Cleveland Clinic. Her primary clinical interests are the surgical treatment of chronic rhinosinusitis and anterior-base tumors. Dr. Stoken will discuss her perspective on patient selection, advantages and limitations for in-office balloon sinuplasty. Dr. Stoken.
Thank you, Pablo, and thank you for having me on this panel. As he mentioned, I was asked to discuss kind of my thought process when it comes to balloon sinus dilation. Next slide. So as was well described in the first talk, the indications for balloon dilation of the sinuses includes these indications, and I listed them on this slide kind of in the order of which I do most commonly to least commonly. The first being chronic rhinosinusitis without polyps. I agree with the workup for these types of patients in that they should have previous medical therapy and CT evidence of disease. I do look for hyperdensities, especially in sinuses like the maxillary and frontal, which I think are harder to get out in the office, and osteitis on these scans, as that can make dilation a bit more difficult. I also want to put a plug in for odontogenic sources, which should be addressed separately before dilating a sinus in the operating room or in the clinic. The balloon dilation systems can also be used intraoperatively in addition to endoscopic sinus surgery. This is often used for frontal dissection. I don't use this routinely, but I think it can be helpful with frontal cells. And so I will occasionally think about it with like a type 3 or a frontal volar cell. The last indication is for recurrent acute sinusitis. And as mentioned previously, there should be evidence of disease in the area you're going to dilate. So these are patients I'm going to confirm have recurrent infections with endoscopy or CT and address the sinuses that could be obstructed and leading to these recurrent infections. I also want to point out that recirculation might be a more difficult situation to address in the clinic. I find it hard to take down the uncinate and find that natural loss in patients who have not been previously operated on. Next slide. Absolute contraindications for me for balloon procedures are patients with headaches or sleep apnea without sinusitis, patients who are asymptomatic, or patients with polyps or any of the other indications listed on this slide. Next slide. I also want to say that for me, the goals of treatment for balloon dilation are the same as they would be for sinusitis with endoscopic sinus surgery. So my #1 goal will be to eliminate symptoms or decrease symptoms. And the second goal will be to open the sinus in order to facilitate medications that will control the disease with the goal of not needing antibiotics or steroids or as little as possible. And a third goal to be to obtain healthy sinus mucosa. Next slide. So the advantages of in-office balloon are these, and that is to relieve obstruction in appropriately selected patients. It's beneficial because people have easy recovery, there's rare complications reported, and you may not need debridements, and if you do, maybe one debridement. And there's also a financial advantage to both the payer and the provider. Next slide. But that being said, there's limitations. So when you're selecting your patients, there are just some people who can't tolerate. So you want to make sure you don't have an anxious patient or someone with a very narrow nasal cavity, which would make manipulating the balloon more difficult. I do want to point out that this is a very different procedure than endoscopic sinus surgery, and that tissue isn't removed. And so these aren't procedures I would use in patients with polyps. I also find that patients where their primary symptom is drainage, that they really get a better outcome if inflammatory tissue is removed. So I wouldn't necessarily think of this as the first option in a patient where they're having drainage, but I would potentially if their symptom was headache or recurrent infection. If you're looking to improve access for topical medications, this might not be the best option. Often we see patients referred from pulmonary or allergy for better control of asthma, and this would not be my first choice for treatment for CRS in those patients, primarily because the ethmoid is not addressed. Next slide. So full disclosure, I see a lot of this in my clinic, and so I don't do a lot of these, but I did line up a few cases here of situations where I feel like the balloon is helpful. So next slide, please. So similar to the case presented earlier, an isolated sphenoid sinus or an isolated frontal sinus with symptoms of headache, I think are good candidates. Tissue removal isn't necessarily needed because drainage and nasal obstruction aren't primary symptoms for these patients, but you can get relief of headaches when you see isolated disease like this. Next slide, please. I threw these on here because you do want to look at the patient's anatomy well with a CT scan and an endoscope before you offer this. If the nasal cavity is very narrow, as I suggested earlier, you may choose to go to the OR to perform septoplasty. And you also want to have a close look at that uncinate process because if it happens to attach to the lamina, you're going to want to be more medial when you place that frontal balloon. And if it attaches to the turbinate or the skull base, then you'll want to be lateral to that uncinate process. And you'll want to be prepared for that before you start your procedure. Next slide, please. In patients who have had previous surgery, I do like the balloon when you see a stenotic sinus and patients who have recurrent infections or headache. I tend to confirm that the headache is in the area where the obstruction is, or that I can track the drainage back to that sinus. But I think this is a nice way to non-traumatically open up the sinus in the post-op period. Next slide. And then the last kind of situation where we think about using balloons is in patients who are poor surgical candidates. So this is a case of a 65-year-old gentleman who had been recently hospitalized with pneumonia, and he clearly looks infected. Next slide, please. He had had a history of sinus surgery without polyps and had been maintaining his sinuses with baby shampoo and budesonide irrigations. And he has this long list of medical problems, including immune deficiency and end-stage renal disease. Next slide, please. So I had treated him with a few weeks of culture-directed antibiotics, and this was his pre-treatment scan, and we followed up very closely after that treatment. Next slide, please. And we were able to see that the majority of the inflammation was coming from this left frontal sinus, which you can see is swollen and has some purulent drainage, as well as the right maxillary sinus, which potentially had some recirculation going on. He unfortunately was admitted and had a pneumonia in the short term after seeing him here. And so once he recovered from that hospitalization, we were able to get him in for a procedure in the office. Next slide, please. And we were able to dilate both the frontal sinuses as pictured here. And we were able to irrigate out and clean those sinuses out. Next slide, please. And then since we were using the balloon in the office and I knew we had recirculation, we dilated that natural maxillary os. And we're able to get the backbiter in there and take down that septation between the previous antrostomy and the natural os. And irrigate that maxillary sinus out as well. And we got him in a better place than he was prior to his hospital admissions. Next slide, please. So for me, the ideal candidate for in-office balloon when the patient's not had prior surgery is a patient without anxiety, with favorable anatomy, with more headache symptoms or potentially recurrent infections rather than drainage or obstruction. And then CT findings after medical management in patients with CRS, or catching them with infections in recurrent acute rhinosinusitis. and in both situations with little to ethmoid disease. You can go ahead and click. So if you see this, I usually think twice about offering a balloon procedure, as I think removing that inflammatory tissue is more helpful. Next slide, please. And then the ideal candidate for a patient who has had prior surgery, I would say, again, without anxiety. And in these cases, if you can trace the mucus from that sinus that's stenotic, or they're having headache over the area that's stenotic or recurrent infections, and you have either a good scope exam or CT findings that correlate with that, and an otherwise good surgical outcome, they're good patients to offer a balloon procedure. And one more click. But if you happen to see osteitis like this, then this is definitely someone you should be considering a revision sinus surgery in the operating room. Next slide, please. That's all I have. Thank you.
Thank you, Dr. Stoken. Dr. Boris Karamfilov, a native of Central Ohio, completed his otolaryngology training at Ohio State and his rhinology fellowship with Dr. Fred Kuhn. He's a private practice rhinologist and skull-based surgeon. He has conducted numerous clinical trials and was involved with the initial balloon trial in 2005 and published the largest clinical trial of in-office balloon sinuplasty in 2011. Dr. Karamfilov will present on indications, anesthesia protocol, equipment, and technique of Eustachian tube balloon dilation. Dr. Karamfilov.
Thank you, Pablo, for that kind introduction. My section for this panel will include office-based Eustachian tube balloon dilation. To be fair, I've done approximately 50 cases in the operating room, however, less than 10 in the office setting. My protocol is very similar to office-based balloon sinus dilation, and patient selection is generally for the mild to moderate symptoms. All patients undergo nasal endoscopic and otoscopic examination looking for retractions, full audiometric and tympanometric exam, and then the ETDQ7 survey. Those patients that have had previous ear surgery or multiple tubes, I generally exclude. And then I also pay attention to other rhinologic conditions, including enlarged turbinates and bulky adenoid tissue. A failure of maximal medical therapy in our practice includes a failure of oral steroids, nasal steroid sprays for an extended course up to 4 months, allergic management, and the use of an otovent balloon. Here's a EDTQ survey. I recommend those that wish to introduce this into their practice adopt this for their EMR, and any score over 26 is considered positive. My anesthesia protocol doesn't include any preoperative anesthetics, no pain meds or anxiolytics anymore. I do use aerosolized Afrin and then pledgets soaked in a 1-to-1 solution of 1 to 1,000 adrenaline or Afrin with a 2 to 6% tetracaine mix. Occasionally we'll use infiltration with a 1% lidocaine with 1 to 100 epinephrine. And then most recently I've been using a 20% lidocaine, 4% tetracaine, and phenylephrine gel. And you can see here's the Afrin, the tetracaine. This is how the gel comes from the pharmacy. I like to do my infiltration with a tonsil style needle. This has a lure lock and a flexible malleable tip, and they come in various lengths. And then as far as the gel is concerned, I have a variety of malleable cannulas, and these can be bent 15 to 30 degrees at the tip, and that's very useful for placing the gel. Equipment room setup, very much like what Roheen discussed with his 2 Mayo stands, procedure chair, endoscopic cart, and we use our SMR table as a back table for equipment, but very similar to the old days of balloon. I've been using the Clarent balloon. I have a good comfort level with this, and you can see dimensions and the nice yellow indicator to indicate the distal location of the balloon. and it is also a vented balloon, which I feel helps as well. This is my case study. KS is a 27-year-old female who is a commercial pilot and has significant ear pain and unable to equalize on descent. She's tried a multitude of over-the-counter remedies, steroids, the Otavent. Her audiometric findings, it's difficult to see here, but she has a mild air-bone gap, along with slight negative pressures on her tympanometry and a survey score of 39. She has no other previous ear surgery. So we recommended to her to try a Eustachian tube dilation. And I think we've all seen these videos. I like to use a 30-degree telescope for visualization. As you can see, she has quite bulky posterior tissue along the torus tubarius. Inflation is held in place for 2 minutes, deflated and removed. And in some of these patients, I've been using a posterior coblation technique of the torus itself, and I'll pick anywhere from 2 to 4 spots, and the goal here is to try to get some reduction of this soft tissue and retraction if at all possible. Briefly, anesthesia protocol, as I mentioned, typically I'll place pledgets 1-to-1 with Afrin and tetracaine. In this case, I was using cotton balls or pledgets, whatever your comfort level is. Then injection or infiltration with 1% Lido, 1/100 epi. I usually do anterior, posterior, and unfortunately our video here was cut off, but we have a cannula that we'll place, and I'll instill approximately 1 cc of gel, and that's our anesthesia protocol. So I hope that helps everyone, and thank you for the time.
Thank you, Dr. Caranfilo. Our next speaker is Dr. Rob Bridge. He has an engineering degree from University of Nebraska and worked for 2 years in human factors engineer at General Motors. He subsequently went back to medical school and completed his otolaryngology residency at the University of Kansas Medical Center. He's in private practice in Phoenix and is the president of ExpertENT, with 3 medical products to treat epistaxis, snoring, mild sleep apnea, and upper airway support via balloon technology. Dr. Bridge is going to discuss patient selection, pearls, and pitfalls of Eustachian tube dilation.
Thank you, Pablo. All right, here we go. So I'm going to go quickly here over what really is the pearls and pitfalls of patient selection primarily. The last lecture was excellent to tell us about what's coming up in the near future to help us out. So the patient selection can be a blessing and a curse. That's probably the biggest thing that I have noticed from doing this about 3 years now, and doing mostly in the office as well. So patient selections, I think the last patient that was provided is an excellent example. So patients that have difficulty clearing their ears with altitude change are, I think, the best patients. Certainly they have often have negative tympanograms, which is helpful, and they just do very, very well. Their scores can be different on the ETD Q7, and that's a really good way to start with patients, and we'll talk about that later. So the patients that might not be your best one are patients that just have fullness, but they do fine with altitude change, or they have clicking, popping, and again, don't have issues with altitude change, and also likely have normal tympanograms. Also, patients with some of those symptoms and tinnitus or dizziness, again, without the negative tympanograms and without the altitude change issues, I don't think do very well, so I would be leery. So the cost is also important to know. In the past, wasn't covered by insurance, and we had to provide it. The disposable costs were high, and I hated to transfer on a huge cost to patients because of the simplicity of the procedure, but we needed to get reimbursed. And so the codes, as I understand, are coming out in December, and then probably the first quarter of 2021 for reimbursement with primarily Medicare, and then the back. So training is very important, and I think that it is very helpful. As the lecture today, we're learning some techniques, some outcomes, but going to a course, we relearn the anatomy, we interject or connect with our colleagues that may have experience that we can learn from, and different techniques that can be done. Some of the latest outcomes as far as the duration of the improvement with the dilation, and then also the latest anesthesia techniques. I just learned about placing some gel up inside the Eustachian tube canal, and that seems quite helpful. So lack of training, which could happen with some companies, is I think a little bit dangerous, and you just need to make that step really to commit to this. I think that would be very helpful. Next slide. So with a race, this is not a race, but again, patients that are going to do well, we've gone over this, and I didn't talk a little bit about sinusitis media, chronic sinusitis media, and repeat myringotomies with or without tube placement. These patients can be difficult. They will likely improve, and if they're chronic sinusitis media patients that recollect after the tubes come out, then they do better. They may resolve, but I have found that some of the patients have a longer duration between loss of their tube and then developing the fluid again. The one patient I can talk about that's not listed is currently in her late 80s, and I think I've put over 100 tubes in her over the years, and I have done the Eustachian tube dilation twice on her, and she was ecstatic in that she went longer without getting the tube back in, and I haven't seen her recently, and I hope she's still alive. So the dark horse, again, we talked about that. There's not a lot of addition here, but you could have some difficulty with patients with significant middle ear dysfunction. Next slide. So here's the Eustachian tube dysfunction questionnaire that was suggested. This is a real good opener for patients. So in conclusion, we're at the finish lines. Again, the codes should come out in this December. The reimbursement, as we talked about. Altitude is important. I think that's your key thing. That's where you want to start if you're just getting into this, is the patients that have difficulty clearing their ears, normalizing, especially the ones that when they come down and they can't pop their ears for several days after a flight. And then my last thing is just no churn and burn. I think when balloon sinuplasty came out, there was much abuse of using them in patients that really didn't need that. And I think this can be a very good treatment for the right patient. And I just would beg my colleagues not to just do this because someone has a little fullness in their ear or whatever. It's just not the right thing to do. Thank you.
Thank you, Dr. Bridges. We appreciate it. We're going to go back now to the session of questions and answers.
Okay.